Hey everyone, how's it going? Let me know if you can hear me. Howdy there, Brian. Isabel and Allison, thank you for joining me today. We'll get started here in a few minutes. Nicole. Hey, Abby. Hard to believe we're already in section 3. My goodness. Pretty wild. Jackson. We'll probably finish up the nephro stuff today, and then we will head into urology. So it's a pretty good segue. Between those, that'll be good. Well, everyone's having a good day. Hey, Aaron. Gavin. Excuse me, Gavin. Not good if my voice is already going out. Andrea? Hope everyone had a good weekend, maybe? Anything fun going on? No? Probably not in the existential crisis that is existence, but, you know, something to distract yourself from it. Studying PD and prepping for OSCE. Yes, that would be good. Oh, that's awesome. Fantastic. Isabel, I'm glad some of you are able to get the vaccine. Hopefully you feel okay today. Harry Potter, all right. Maybe getting vaccinated for the future fun you can have. Perhaps that works. I know, what is this fun you speak of? Not much to be had around here, right? Yeah, my arm hurt pretty bad after it. I was okay after the first dose, but the second dose kind of wiped me out. 24 hours out. Oh, no, Kaylee, I don't want to have a CSP meeting where I have to say, well, the student's been playing 400 hours of Stardew Valley this semester. Think about their data production. Think about it. There you go. Yeah. I got like a really bad knot on my arm. Someone has a good. All right, so we can get started here. Problems and stuff. I got a chance to finish our sci-fi RPG with Richard, Danny, TC, and Peter. Cool. That sounds like a lot of fun. Glad you guys had a good time. Oh, it's funny. Right after that's a thing. You have no idea if whether it's the vaccine or my lectures that are giving you your side effects. So it's a little bit of a confounder there. But anyway, let us begin. Someone asked, if you take a medication that makes you drowsy, can you combat that by taking caffeine? It's a good question. It's kind of like the idea, like, can you sober up with caffeine or coffee or something like that? It may like counterbalance the effect a little bit, but there's no guarantee. A lot of it has to do with how sedating the medication is, dose, all those kinds of things. If I took a Benadryl, 25 or 50 of Benadryl, and I was a little, drowsy, I took a caffeine, maybe that would be one thing, but now you have to also consider the fact you may have an impaired person who is also more energized to do silly things. So as an example, I'll give you, I don't know if anyone was familiar with the cultural phenomenon that was Four Loko, back when it had caffeine in it. And so that was really kind of a big challenge from a toxicology standpoint, because for one, it came in, I think it was like a 10 or 12% by volume alcoholic beverage. It came in this like big tall boy kind of, where's my other hand? Tall boy sort of drinks, and then it was like heavily caffeinated. So you'd have these people that were really drunk, but were awake enough to be able to like do stupid things like go drive a car or something like that. And so I did have one. Yeah, stuff was rough for sure. I did have a colleague whose brother was underage and ended up drinking one. The other thing too is it's like also like you're awake enough so you can like continue drinking, so I get you even more drunk. Whereas otherwise you might have like passed out or something. And it was created by Ohio State students. I did not know that, but it is a fun fact. Anyway, so this colleague of mine, her little brother got into drank an entire one and decided to take out the family car and ended up passing out at some point and woke up in the wrong direction on an off ramp for the freeway. So yeah, and now you can still get it. It just has the caffeine removed, but it's the same idea as like a Jaeger bomb or something, where you're combining caffeine plus, or no, Red Bull and Jaeger, whatever. I think it's a Jaeger bomb. Kind of out of the drinking game, but anyway, yeah, so that's the idea. So you may have someone who's more alert, but they're also like still inebriated. So I would not recommend. That's my ultimate answer there. Okay, so getting back to it, crazy kids indeed. They will. You never can underestimate what adolescents will do with a excess of time and a lack of wisdom. You will find that, yeah, lots of things can happen. Anywho, so getting into this, we were talking about kidney injury. We're talking about acute tubular necrosis in terms of drug-induced kidney injury. This is being a pretty common way that this occurs here, especially in the inpatient setting. You can see here just a ton of different drugs that can be responsible for this, including aminoglycosides, and we'll go into some more details on the specifics here. If I'm getting off on the wrong slide here, just let me know. So aminoglycosides, this is one we really have to watch carefully, especially in critically ill patients, because you'll find that it happens about 5 to 10 days or so after therapy initiation, especially if you're not really tracking it and watching things like their making sure their trough levels are undetectable and things like that. And you'll see this kind of gradual increase in BUN and creatinine. Remember, it takes some time for creatinine to really catch up when you have an acute decrease in GFR, just because it has a half-life, so it has a steady state that it must reach then. Generally speaking, if we can recognize it and like switch them over to something else, or if we can try to preemptively follow their levels to make sure that they're not accumulating the drug, that's going to be really beneficial. So for instance, we do a lot of like Q24-hour dosing for this, and let's say like before the third dose, we'll get a level and we'll get a trough and make sure that it's undetectable. If it's detectable, that shows that they're accumulating some of it, and we want to make sure they get rid of that. Otherwise, that kidney injury could happen there. And so you can see this happens with accumulation, especially in those proximal tubular cells. And so what happens is that basically you have these reactive oxygen species that are generated that damage mitochondria and all kinds of other things that causes stress on those cells that leads to their death. And some other things that could maybe predispose these patients to would be if they have prolonged therapy, so if they're on it longer than they need, large total doses that are not really being accounted for with therapeutic drug monitoring, and if the trough concentrations are a big one, as I mentioned there. And then the one thing you also want to consider too is, are they on other nephrotoxins? Like, are they on vancomycin? Are they on loop diuretics? Are they on other things that could potentially be complicating the picture, right? NSAIDs, ACE inhibitors, things like that can also potentially harm the kidneys, and they just compound on one another, which can make it a challenge there. So ideally, what we'd like to do is if you can try to use an alternative antibiotic, that would be ideal. However, you may be limited in terms of your options depending on if the patient has Pseudomonas or something. You may not have a ton of options that are there, but certainly we can limit concurrent nephrotoxin use. So for instance, if they have a fever and they need an antipyretic, try Tylenol instead of ibuprofen. That's one way to get around it. And then we do that prospective pharmacokinetic monitoring. Now, again, you may be lucky enough to work in a place where you'll have pharmacy service that can do this for you, but you may work somewhere where that's not available, and so you need to do it yourself. And so there's a lot of protocols and things like that. So one of the ways we can try to streamline therapy and make sure that we don't have a lot of people doing different things. And so one of the things we've done to try to streamline that is to do once daily dosing, because that gives you a really large dose up front that gives you that nice post-antibiotic effect, and it gives the patient 24 or more hours to basically eliminate the drug, and it reduces that accumulation. So we'll give like a really big dose once daily, and then we can measure a trough, and it should be undetectable. But even though it's undetectable, that's okay because it has that post-antibiotic effect, which is great. And then if we notice that they have acute kidney injury and we suspect that it's the aminoglycosides, obviously we'd like to discontinue therapy if at all possible. Looking at radiographic contrast media nephrotoxicity, or if you see it, contrast-induced nephropathy, that's another term you'll see there a lot, CIN, or I guess SIN, you could abbreviate it. You can see that it has been decreasing in terms of incidence. I think one, because a lot of people have realized how big of a problem it is. We've realized some ways that we can try to mitigate this if at all possible. But it's probably the third leading cause for hospital-acquired kidney injury, right? Very unlikely in people with normal renal function. So typically they have pre-existing renal disease, and now you're adding this new contrast-induced nephropathy on top of that. And the problem is that we can see that a lot of patients do have decreased or have increased risk of death, increased mortality as if they do develop this. So we try to really prevent this as best we can. Again, there's a lot of protocols in place to try to limit that. Typically it's about 1 to 2 days after administration there, and you'll see oliguria typically reported in those high-risk patients with like pre-existing kidney disease. That's what they're going to report there. What's happening here is that it is related to sort of either direct renal ischemia and toxicity to the actual cells themselves, which can happen there. And then you can see here as well that due to the high osmolality of a lot of these substances, basically, about 600 to 2,000 milliosmoles per kilogram. I guess that should be liter there. As opposed to your blood, which is like 300 on a high day. This is pretty hyperosmolar, and so that can lead to some issues in terms of direct damage done to the kidneys, and so that's why it becomes such a problem there. As I mentioned, pre-existing kidney disease, so if they have a creatinine clearance less than 60 mLs a minute, like that definitely predisposes them to it. And then if they have reduced renal blood flow, right? So that's why we mentioned you really want to get those patients tanked up with fluids beforehand, before they get the contrast, because that will help to make sure the kidneys are staying perfused, right? So if they have reduced renal blood flow due to hypovolemia or hypotension or something like that, then that's where that risk certainly goes up. Ways we can try to prevent this is, one, try to look for those risk factors beforehand, and don't always assume that your radiology staff are going to be able to do that for you. So you have to make sure that you're making the determination as well. And so one of the things we can do is try to minimize the dose that we use, so just as much as we need for the scan we're doing. And then nowadays we're able to use either non-iodinated contrast studies, so by using a non-iodinated form that has less stress on the kidneys. And then nowadays we also have low or isoosmolar contrast agents, and this is what's helped to reduce this quite a bit, is by using something that's more isotonic or hypotonic. It helps to decrease a lot of that just stress that it puts onto the kidneys by having something that's really hypertonic in a lot of those cases there. Again, avoid concurrent nephrotoxins if we can. And then, as I mentioned, we'll give them isotonic crystalloids. So 0.9% sodium chloride is perfectly fine there. If you recall, we talked about crystalloids and tonicity before. And again, if you have 3 to 12 hours before the exposure, that's good. However, you may have some emergent cases where that's not possible. So at the very least, you can try to tank them up afterwards and continue IV fluids for about 6 to 24 hours post-dose, and that's one way we can try to help prevent that. Just keeps the kidneys nice and perfused so they can flush that stuff out as quickly as they can. Some people have tried things to try to prevent this from occurring, which we've kind of touched on before, like the N-acetylcysteine. This one, again, there's some potential benefit for really high-risk patients, although, again, it's hard to do studies to really show conclusively one way or the other. Some people have tried doing bicarb as well. Some people feel like you have less free radical formation if you keep the pH, normal to neutral to high. However, I think this is pretty controversial, so I don't see this used a lot. I do see some N-acetylcysteine being recommended. Again, there's very little downside to using N-acetylcysteine, so most people will try it out, usually for a day before and then 2 days after, typically. There's some different treatment strategies depending on the case there. And for management, not a lot you can do. Basically support them through it, make sure to keep their volume good and their electrolytes good and all of that from that standpoint. Another common cause for ATN is going to be cisplatin-related nephrotoxicity. If you recall, this is an alkylating agent that we talked about back in the oncology days, those many months ago. And again, this is a major dose-limiting toxicity, is the kidney injury that you can induce here. And so basically what's happening here is you're going to notice they're going to have this impaired tubular reabsorption due to that damage to those cells. They just can't operate anymore to reabsorb things effectively. And so you're going to not be able to concentrate the urine very effectively. So you see that polyuria, you're going to see electrolyte wasting like magnesium and potassium, just because the cells aren't able to reabsorb that stuff that gets filtered like it normally would. A lot of this is due to accumulation of those cells. And remember, the alkylating agents, they can't tell the difference between a healthy human cell and a cancerous cell. They just kind of attack everything, which is why they tend to be so toxic. And so when it attaches those proximal cells where a lot of the reabsorption occurs, that can cause the cell damage to happen, the apoptosis, and then again you lose that concentrating capability. Ways that we can prevent this is to try to reduce dose and decrease the frequency of how often they're getting it. And you'll see this in a lot. If you work with oncology patients, you may see that they will have dose reductions factored into their roadmaps for what drugs they're going to get based off of their renal function. You also want to avoid concurrent nephrotoxins, and we do really vigorous hydration for these patients. So we'll do like 12 to 24 hours of isotonic fluids. And again, our goal urine is probably about 3 to 4 liters per day. So we'll do that and continue it up through after they get the dose, about 2 or 3 days afterwards. There is one thing we can try using here, which is called a mifestine or ethiol. And this is basically a chelating agent here. So we use this occasionally. Most of the time, vigorous fluids are typically enough. But here what we can actually do is give this a mifestine 30 minutes prior to the cisplatin, and that can help to chelate it to prevent it from accumulating there in the kidney. So that's one actual antidote sort of agent that we have that's available there, which is nice. Do want to watch out for hypotension with this, and is reserved for those that really need the drug, but maybe have some kidney insufficiency that are high risk for developing worse ATN from cisplatin. So not used for everyone, but for high risk patients is pretty good. Most of the time, normal saline is going to be fine for those patients. Again, they may be getting 250 mLs an hour, so usually twice maintenance in a lot of cases there, so it can be quite vigorous in terms of hydration. If this does happen, generally it's going to be partially reversible because, again, those cells may not have the good ability to really come back from that. And so in rare cases, we may need things like RRT or dialysis treatment and then electrolyte replacement. So if they're leaching out a lot of potassium and magnesium, you can replace that. And remember, normally if you think about kidney disease, you think about hyperkalemia because they can't clear it. In this case here, they're wasting it, so that you may need to actually replace it. So it sounds a little counterintuitive, but that's the case there. Another really nasty drug here, amphotericin B, right? We talked about that. So amphotericin, it's used for more systemic fungal infections, usually in patients who are immunocompromised, who develop these systemic fungal infections. And you can see it's like 30 to 80%. So it's a really, really horrible drug for the kidneys. And you get similar wasting like you'll see with cisplatin. So you're losing potassium, sodium, you're losing mag, and you get this renal tubular acidosis because you can't really reabsorb bicarb anymore, so you just pee it right out. And this is typically seen, a couple days to weeks after the initiation here. And again, usually due to direct tubular cell damage. It's not really able to, tell the difference between a fungal cell, at least the ergosterol in the fungal cell, versus some small amounts of ergosterol that we have in our cell membranes. Not only that, but you also have this afferent arteriolar vasoconstriction. So you have direct damage done in the kidneys, but you're also clamping down on that afferent arteriole, meaning less blood flow is getting in, so you end up hyperperfusing the kidneys as well. So kind of a double insult from that standpoint, kind of a pre-renal plus an intrinsic sort of injury that you're causing there, which is not great. So obviously people that have pre-existing disease are more likely to have this, of course. If you're using larger doses, larger periods of time you're using it, concurrent nephrotoxins, some of these things seem kind of consistent from drug to drug. One of the ways we can try to prevent this is actually using a liposomal form of the drug, which is kind of neat. So basically, you'll form these micelle or liposomes here, which have these phospholipid bilayer, where the drug is actually sort of sitting and resting in this. So it's this little, call it, ambisome. This like very lipophilic kind of molecules that hold the drug, and they basically prevent it from really interacting with the kidney cells as much. And so the downside, though, is it's much more expensive. It's more difficult to formulate a drug like this versus typical just regular amphotericin B, which is cheap, like $5 a day for that versus up to $1,000 a day. If you have these really invasive fungal infections and no immune system to fight it, then you may be on it for weeks potentially. So you can see how it does certainly add up over time. Other things we can do is we can make sure we have adequate perfusion of the kidneys, so make sure you give them plenty of fluids, and give them longer infusion time, so maybe over an hour or more in those cases there. Again, may not be reversible in all cases, and we can just replace the electrolytes that we need. Again, switch them over to the liposomal form if you can. It's very rare nowadays I see just plain old amphotericin B being given. And then talking about intratubular obstruction here, we can see this is where we mainly have precipitation of drug crystals in the distal tubular lumens there. And so this can either lead to like an interstitial nephritis. You can have this superimposed on top of an ATN, especially if it's happening within the more proximal portions of the renal tubule. But in and of itself, it can actually cause an obstruction. So not only is it causing, these crystals are forming and piercing these cells and causing direct physical damage, they also have an obstruction here that causes backup into the nephrons themselves. So as I mentioned, this is precipitation of drug typically, or it's going to be a drug that is causing the release and precipitation of tissue byproducts, right? So it's not just that, something like acyclovir will precipitate out, or methotrexate, like we've talked about previously. But if you have something that causes rhabdomyolysis, like we talked about with the statins and the CYP3A4 inhibitor, for instance, or if you have something like tumor lysis syndrome, where someone has a very high white cell count, you give them a chemotherapeutic agent, and all of a sudden all these cells start to lyse open, all those purines start to be metabolized. You see uric acid start to crystallize out. So those are things we can see. So a lot of times for like patients who are at risk for tumor lysis, we'll actually give them allopurinol. And if you recall back when we talk about gout, allopurinol is a xanthine oxidase inhibitor that prevents uric acid from being formed. And so we may do this as a preventative in those cases there. Actually, I had a patient just recently who had a condition where they're having a lot of hemolysis and was running into the same issues as you would see with tumor lysis syndrome. We ended up having to give rasburicase because of that, just as an example. Remember, that's a drug that directly breaks down uric acid to prevent those kind of kidney injuries from occurring there. And then other things that can lead to drug precipitation, typically it's related to low urine volumes or volume depletion, and then low drug solubility. Okay, so that means that if the pH is such and that the drug is concentrated enough, it will come out of solution. And I'm sure you've experienced this like in your undergrad chemistry classes or something, where if you change the pH, things may go in and out of solution. This is the case here. So big ones that cause this are going to be acyclovir, which are in methotrexate, which I think are probably the most common ones you're going to run into, and foscarnet, which is another antiviral drug, can precipitate with calcium and cause these crystals to form as well. Anyway, and again, of those cases there, that's where we frequently treat it by doing things like giving sodium bicarb with methotrexate, or just making sure that we're hydrating the patients well in order to make sure this crystallization does not occur. That's really the best things we can do for those patients there. Okay, so that's pretty much it for drug-induced kidney injury. Just be aware of like things that we can do to try to prevent it, things that we can do to try to treat it. Like for instance, if I'm having something like amphotericin-induced, kidney injury, I may need things like potassium replacement or magnesium replacement as an example. So little things like that. Anyway, now let's talk about disorders of sodium homeostasis. So basically, and some of this might be review for you guys, which is fine. If you have any questions, certainly let me know. But what you can see here is that your total body water is made up of both an intracellular compartment and an extracellular compartment here. So 60% of total body weight is probably, or total body water is going to be intracellular. That means that a lot of the osmolytes that are making that up, so inside the cells, are going to be things like potassium, things like phosphates and whatnot, right? The extracellular compartment here is about 40% of your total body water is like sodium, chloride, and bicarb, right? That makes sense because when you look at, say, a Chem 7 or a BMP, the sodium is much higher than the potassium, even though your body probably has similar amounts of sodium potassium in it. It's just most of your potassium is relegated to being inside the cells. And this balance here between sodium and potassium is maintained by the sodium potassium ATPase pump, right? That shouldn't be any new news for you guys. But what you're going to find is that ideally the osmolality between the ICF and the ECF should be relatively similar, and that it allows for water to sort of permeate freely, not really causing any major shifts to occur there, and then homeostasis is achieved and everything is good to go. As we mentioned, when you give something like an isotonic fluid, like 0.9% sodium chloride, there's no net shift in the ICF or the ECF because it's isotonic to the blood. Whatever volume that I add into the intravascular space, it kind of just stays there. It's just, which is good because if my patient's hypotensive or tachycardic, I can put that fluid into the vascular space where it stays and it's filling up that space, and that's good, and that will allow pressure to come up and the heart rate goes down, everything's good. What we can do, though, is by changing the concentration of the solution, we can cause shifts of fluid either to go into the intracellular compartment, or we can pull it out of the intracellular compartment, okay? And this should make sense if you recall going back and looking at like toxicity. They always have like a blood cell, and they show it like in the isotonic solution versus hypertonic or hypotonic, and you can see how it can crenate, or it can try to expand out and explode potentially. We can kind of do similar things here. And so you'll find with hypertonic solutions, so anything above 0.9% sodium chloride will decrease intracellular fluid compartment because it's going to draw water out of that compartment and into the ECF, okay? So for instance, if I have someone who has fluid accumulating on the brain, so I have cerebral edema, I can give hyperconcentrated sodium chloride, and that will draw water out of that compartment and into my ECF, so that way I can get rid of it, I can pee it out, okay? On the opposite hand, if I have hypotonic solutions, or anything less than 0.9%, that's going to cause water to go away from the ECF and into the ICF. You're going to have more water dissipate out into those tissues, which may be okay. That may be good if you're dehydrated because you've been vomiting for the past week or something, okay? So again, the purpose is really important in the context of how we're administering this. So here's a nice table that kind of shows you the difference between various solutions and sort of the tonicity and the free water. And again, free water means that it's basically available to go into the intracellular compartment. Okay, this is water that does not stay in the veins. It will go out into the tissues. So it's termed free water. And as I mentioned with D5W, that dextrose doesn't stay in the blood vessels very long. It likes to get uptaken into the tissues, be used for energy. And so even though D5W is technically isotonic in the bag itself, once it gets into the patient, it's considered to be hypotonic, and most of that free water you're going to see is going to mostly end up in the ICF. Not as much of it's going to stay in the ECF due to that. Okay, so that's considered more hypotonic. Similarly with 0.45%, or half normal saline, you can see here the concentration of sodium chloride is lower than what our typical serum levels are. That is also considered to be hypotonic. And so you're going to see most of this is going to stay, while in the ECF, you'll see a decent amount of it will go into the ICF. So this may be good for cases where you want to have patients rehydrate their tissues, right? They've been vomiting, having diarrhea for several days. This may be a good thing to help kind of hydrate those tissues up instead of just keeping it in the vasculature. On the other hand, things like Ringer's lactate or lactated Ringer's, normal saline, you can notice here that they are isotonic. All that volume is going to stay right there in the blood vessels, and that's good for those cases where you're trying to tank them up, or they're intravascularly depleted. That's very good from that standpoint. And then here you notice 3% sodium chloride, so over 3 times as concentrated as normal saline is. You'll see here this very hypertonic. It's going to pull fluid out of the intracellular compartment into the ECF, so that way it can be eliminated through the urine. So anytime you have someone who's having severe cerebral edema is the thing I most often think about is using sodium chloride for concentrated sodium chloride. That is to draw water out of the ICF and into the ECF, so that way you can pee it out, basically. If this doesn't make sense, just let me know. I'm really fine because some of the stuff does get complicated, as we'll see here. We do know that sodium is pretty tightly regulated here, and so that has to do, and based off our serum sodium, that can affect our plasma osmolality and also the blood volume, okay? Kidneys are going to be able to help out quite extensively with water excretion through the hypothalamic feedback, so both through like aldosterone and ADH and all of that. And usually we should be maintaining our serum osmolality between 275 and 295 milliosmoles per kilo, okay? We'll also see that things like osmolality can be affected by glucose, by BUN, and even volume shifts can be affected by things like protein in the blood. Like if you have low amounts of proteins, you may not be able to hold as much stuff in the vessels due to less oncotic pressure. So John's saying, which tonicity would you give to someone who is, say, dehydrated from drinking? Would that be a hypotonic then? That's a good question. So let's see. Yeah, so let's say for instance, like we have someone who, I would say for someone who is dehydrated after a single night of drinking, they probably don't have a whole lot of like tissue dehydrations going on there. Probably more is coming from like an intravascular sort of case, because again, you just urinated out over the course of the 8 to 12 hours. And again, that's where you get a lot of headache coming from too. So you're probably fine giving normal saline. And honestly, the key to a lot of this is that normal saline is going to be fine for majority of these patients here, right? If I had someone who like over the course of like days to a week or days to like maybe a week where they were have vomiting, diarrhea, things like that, I would more lean on using something like 0.45% sodium chloride to try to rehydrate those tissues there. I will tell you, you never ever use D5 by itself. Because of the fact that it's all free water, you at least want to give them some amount of sodium. And again, think about that. Free water is diluting out the sodium in your body anyway. So one of the other key points I'm going to be making here is that anytime you're giving something less than 0.9% sodium chloride, you do run the risk of causing the patient to become hyponatremic. And again, iatrogenic hyponatremia, something that we cause the patient to develop, is a very common thing and something that you'll see that we're moving away from in a lot of cases. At least in children, I'm seeing much more so, because again, I don't work with adults as much. That for a lot of times, like for maintenance fluids, we're just using D5 and S because we do see too many cases of hyponatremia from someone being on a half normal saline drip for days, and then no one goes back and checks their BMP, right? Because again, the body's pretty good at being able to regulate sodium. So typically, if you want to rehydrate the patient, 0.45%, it might be a little bit better from that case, but I'd say that's on the more of a course of maybe days to a week, right? If it's like a single overnight kind of thing, or if I had a patient who was at a boot camp in the middle of July and they became dehydrated, like normal saline's fine for that patient too, right? Because a lot of times you're going to find they're intravascularly depleted, and I want to tank that back up, and normal saline's like the best thing for that, right? And again, if you've seen something different, it could be because the context was different or something. Let me know. We can kind of talk it out and kind of go through that. Anyway, so what are some of the things that help us to regulate sodium in water? Well, arginine, vasopressin, or antidiuretic hormone is important here. And you're like, well, like, why are we getting like a endocrine rehash of this stuff? What do you know about this? Again, we can give ADH. We can give vasopressin as a drug. So this is why I kind of mention it here, because it is pretty important in terms of helping to regulate things like blood pressure and osmolality. Anyway, naturally though, and again, that's why you pee so much after you and get dehydrated after a night of drinking, is because you're actually turning off your ADH secretion, and that way you kind of break the seal, so to speak, and you have a lot of urination associated with that. But anyway, we will find that AVP or ADH, whatever you want to call it, is going to be released from the pituitary in response to increased osmolality. So typically, when you have a concentration of the blood causing increased osmolality because you're dehydrated or whatever the case may be, you're going to find that's going to cause ADH to be released. That's going to cause that thirst response to try to get more salt and water coming into the system. And then it's going to basically be working at the site of the renal tubules to try and cause more aquaporin channels to be inserted, so that way you absorb more water, okay? So remember here, AVP in the kidneys themselves just cause water to be reabsorbed. It doesn't have any direct effect on sodium or potassium excretion, which is at odds with aldosterone, as we'll see there a little bit. Not only that, and again, if you have patients who have like an inappropriate amount of AVP or ADH, so SIADH, which we'll talk about later on, those are the thirstiest people you're ever going to see in your life. They will like sell their mother off to just get a glass of Gatorade or something because they're so thirsty. That response is so strong for them, which is really wild. But you also see the renin-angiotensin system will be also upregulated during this as well. And that's responding to that decreased circulating volume, right? So decreased pressure is another response they're going to be you'll be seeing there. Now, when you're looking, so knowing that, I want to talk about sort of cases where you're going to find hyponatremia, how we treat that, and then we'll talk about hypernatremia a little bit later on, because this can be a very life-threatening sort of situation here. And so some of the things we're going to be looking at is trying to determine whether a patient is developing a isotonic hyponatremia, a hypertonic hyponatremia, or hypotonic hyponatremia, because the causes can be quite different, as we're going to see there in just a little bit. And by identifying the cause, that'll tell us sort of how to treat it, as a case may be here. So we're going to go through kind of all these situations here, and these are ways that you can try to identify kind of what's going on. But I kind of just want to note some of the different things we can find here in terms of like reasons why a patient might develop hyponatremia, look at some of the causes of why that is, and ways we can try to treat that. And again, we're going to find some drug-induced causes here as well. And so I like to identify those because that could be a good intervention. You could basically fix the patient by stopping a drug or something, as an example. We're going to find that the hypotonic hyponatremia typically has the most myriad number of causes, because you can have either a hypovolemic, hypervolemic, or euvolemic situation. And we're going to get into all of these more specifically as we talk about them. This is probably where we're going to spend the most time, though, is talking about our hypotonic hyponatremia. So first off, when we have someone has a low sodium, which again, normal sodium is 135 to 145 milliequivalents per liter. This is someone who's less than that, okay? If there's a hypertonic hyponatremia, this is usually due to the effect of having some other sort of osmol that's around that's diluting out your sodium, or is basically contributing too much to that osmolality calculation, and is increasing the osmolality, right? Oftentimes, this is going to be seen with things like glucose, having a very high glucose level, which again, if you're calculating a serum osmolality, use sodium, BUN, and glucose in that calculation. You will find that having very high levels of glucose in the blood can actually cause shift of fluid to the ECF, right? Because if your osmolality in the blood's going from, say, 290 up to like 400 or 500, you're going to draw water out to where the higher osmolality is to try to balance that out, right? So it can actually dehydrate the cells because you're drawing all that water into the blood, to the vasculature, basically. But having that happen also dilutes out your serum sodium. So looking at that, you may not actually have a hyponatremia. The level looks low, but the total body amount is actually normal in those cases there. What's really interesting is if you have a patient, especially who has like HHS, for instance, for every 100 milligrams per deciliter increase in glucose above the normal, your serum sodium drops by 1.7 milliequivalents per liter. So someone who comes in with like a glucose of 500, you can see 4 times 1.7, you can see how that drops down fairly quickly there. So that's one thing to always consider with someone who has extreme hyperglycemia. That hyponatremia may not be real. It could just be a dilutional effect you can see there. And fix the glucose, you'll fix the sodium as well, right? Other things can do this too, like hyperosmotic agents like mannitol, but this is less likely to be due to a drug-induced cause. It's more likely due to like a diabetic sort of situation. Now, hypotonic hyponatremia is probably the most common and has the most number of causes to it. And one of the first things you want to do here is try to demonstrate or try to determine the patient's volume status. Are they hypovolemic? Are they euvolemic? Or are they hypervolemic? Again, you guys are the experts on physical diagnosis. You could probably teach more to me about how to determine this than I could to you, right? So I'm not going to be covering that specifically, but once you have that determined, you can try to figure out what the most likely causes for that are. So let's say we have someone who has a hypovolemic hypotonic hyponatremia. I know this stuff gets a little bit confusing based off of all the hypos and hypers and whatnot, but stick with me here, right? So this is someone who has low sodium, their serum osms are low, and also they are volume depleted, okay? This is generally due to just fluid loss, right? So if you're vomiting, having a ton of diarrhea, or say you have someone who's abusing diuretics, this is a cause for this, right? Maybe not abusing, but just using excessive diuretics. You can see that this is a case here. So again, when I'm using a diuretic, like a loop diuretic, I'm not just losing water, I'm also losing salt along with it, okay? And salt is a major contributor to your osmolality. If I'm vomiting or having diarrhea, I'm not having time to reabsorb a lot of that water, so that loses a lot of solute along with it. So those are main causes for that. And again, you're going to see that you'll stimulate AVP, which makes sense because, again, low sodium, low osmolality is being detected by the kidnees. So it says go ahead and increase the release of that. And you'll find that the patients will have this polydipsia, right? Because they'll have a thirst stimulation. Well, what do they frequently reach for? Well, they'll go for like Gatorade or go for water, which honestly isn't really enough solute for them to really replete what they're missing. And so they end up developing the hyponatremia. So they're losing salt, they're losing water, they're just getting free water in a lot of cases, or not enough salt to really replace what they're missing, and thus you have the hyponatremia that develops here, okay? Usually you're going to find in those cases there that the urine osmolality will be high because the AVP is trying to concentrate that. So it's trying to pull out as much water as it can, and the urine will end up being pretty concentrated there. You'll see this also as well with like thiazides, although it's mostly asymptomatic for the most part. You may see a little drop in your sodium, but for the most part, it's not going to be that huge of an issue, especially with time. The body gets used to it. As you'll see, it will adapt to it. For the euvolemic hypotonic hyponatremia, you're going to see here that you'll have a normal amount of ECF sodium. So the sodium level is relatively normal. The total amount is, the level is going to appear low, but the total amount in the body is okay. But this is due to having an increase in the total body water and the ECF volume. Okay. And the patient will appear to be volume neutral, right? They may not have like obvious like signs like, pedal edema and, have a bunch of crackles on the lung exam and things like that. They may not be apparently volume overloaded, and they generally don't because they appear to be euvolemic. And so this is most often a issue of SIDH, the syndrome of inappropriate antidiuretic hormone. This is probably the most common cause for this. And there's a lot of things that can do this, not only drugs, but we're going to see there are several other causes for this as well. So things like certain cancers can do this, things like head trauma. I would see this a lot in my time in fellowship when I got to rotate in the surgical ICU. You'd have patients who get in motor vehicle accidents who would come in after a head trauma, and this is frequently what was keeping them in the SICU for so long, is because they couldn't regulate their sodium very well because of this SIDH they had after that head trauma. You'll see this with stroke, meningitis, pulmonary disease like pneumonias and TB. And you can also have like a primary or psychogenic polydipsia. So they're taking a ton of water. The body is able to get rid of some of that water, but it ends up kind of diluting out what's there. So again, it appears to be like they're hyponatremic, even though the total body amount is probably okay. Oh my goodness, someone has a whole story here. I love this. Let's see here. Someone says, I know a power lifter that cut about 12 pounds of water over 1 to 2 days for his meet 2 weeks ago. After weighing in, he used an IV and oral rehydration method, and he gained all 12 pounds back in 1 day. However, over the 2 days after the meet, he was up 40 pounds and super edematous. Is this a compensatory mechanism from the dehydration rehydration? The case of improperly rehydrating, he is now within 5 pounds of his original weight. It's crazy to see him go up 40 pounds in seemingly water weight. That's a good question. I also think too, and again, my knowledge is limited in terms of powerlifting, but don't they also consume a lot of carbohydrates to help them kind of bulk back up in terms of that weight prior to the meet? And so some of that also draws in a lot of water too. And so that may be sort of a compensatory thing with that as well. That glucose will also draw in a lot of water additionally into the cells. So that may be a relation to that. Other than that, I'm not really sure of any like smoking guns necessarily. I wouldn't say it's like a improperly rehydrating, but could just be as a result of having all that increased carbohydrate and protein intake and just kind of sucking up all that water into the cells and being kind of extra puffy. So that sounds right to me, but maybe if other people have more experience, they could clue me in. John says yes. You seem like a strong lad, so maybe you have some experience, or maybe not personal, but maybe you could elucidate on that if you have any ideas. But or just a single yes may work. A man of few words, perhaps. Anyway, yeah, so SIDH is a pretty common reason for this, as we're going to see here. And so I like to focus on the drug-induced causes as well, since they are numerous. And again, you can try to find the smoking guns here and say, okay, well, obviously it's this, so let's try to get rid of it and see if you can fix the problem. Well, and then it also gets kind of complicated here as well, because of the fact that you can find that it is could be a number of causes there. Oh, it was your question. You didn't want to distract. That's fine. I love being distracted. I don't know if you guys knew that or not, but yeah, that's I love that kind of stuff. I think all that stuff, like especially like performance enhancing drugs, are like super interesting, like blood doping and using hormones and all kinds of stuff. I wish there was like a superhero league where we could just like let people use as much stuff as they want just to see what the limits of human capabilities are, but that probably is not ethically great on their bodies, so maybe we shouldn't do that. But regardless, so looking at the drug-induced causes, you can see that the mechanism may change actually depending on the drug that you're dealing with. So for instance, some things will cause an increase in ADH release, right? So things like nicotine can do this, tricyclic antidepressants can do this. That'll actually be important here in just a little bit, as we'll see. Vinca alkaloids like vinblastine or vincristine, haloperidol, opioids, these are not things that are necessarily super common for most patients, but this could be a cause for that. So imagine that patient who is in the surgical ICU, they were on the ventilator and they're receiving, a large amount of opioids. So they're receiving fentanyl in order to help them, with their maintenance of their sedation. That could be the reason why they're having SIDH, right? In some cases here, you're going to find an increase in sensitivity to ADH. You'll find that the kidneys are responding better to it. So things like carbamazepine, lamotrigine, NSAIDs can do this, right? We talked about how like carbamazepine and oxcarbazepine can lead to hyponatremia is one of those things that you want to monitor for, especially, right? So that could be another case there. And then sometimes it's a mixed action, right? So things like ACE inhibitors, SSRIs can do this. And one that I always find really interesting is methylene dioxymethamphetamine, otherwise known as MDMA, otherwise known as ecstasy, otherwise known as Molly. Depending on your generation, you may find different names for it. I just like to spell it out because I love how long that name is. But MDMA is really interesting. I've seen a few cases where patients will come in, and it's really wild because not only will they have this SIADH that's happening here, but also if you think about like where they're using these products at, as you think about like, think about music festivals and things like that. Imagine going down to, what's the one in Orlando? I don't remember the name of it. I've never been to it, obviously, but they have a lot of like South Florida and stuff like that. So if you imagine the ones there where it's like super hot outside, you're being surrounded by like a gazillion people. EDC, thank you. You're surrounded by a gazillion people, and so and of course like you want to drink some water, but it's like probably like $14 a bottle or something like that. So not only that, you're sweating, you're losing salt there, you're you're losing volume, and then you have this methylene dioxymethamphetamine, this amphetamine that you're taking that can cause an SIDH as well. So I've seen some really severe cases of hyponatremia and seizures related to MDMA use, and again, these drugs will make you hot anyway, just because of its amphetamine-like action. I think I'm identifying all like the electronic music kids here in the class. You're not kids, you're students, but anyway, yes, EDC is the one I was thinking of. Appreciate that. If I needed any other ways to show I'm not very cool, that would be probably another one. What's that? What's that techno music these people go to? The techno concert? Anyway. We'll get into treatment here in just a few moments, but the final thing here is the hypervolemic hypotonic hyponatremia. This is where you're going to actually see that the kidneys are having a problem excreting the sodium in water, and so you end up developing like edema and this like expanded extracellular fluid volume. And again, you're going to see, actually what's interesting enough is that you get this decreased effective arterial blood volume, and so that causes even further sodium retention and edema. This is most often where you're going to see this with things like CHF, cirrhosis, nephrotic syndrome, beep bop boo boo bop. Yeah, that's my favorite song. I love that one too by that guy. Bipple, is he one? I don't know. Anyway, so this, you'll see this a lot too, like nephrotic syndrome, cirrhosis, and things like that. That one I'm not going to focus too much on. It really depends on. Glad you guys are appreciating my ineptitude. That's Mr. Krabs' favorite song. There you go. Anyway, I should probably know that then. I do like SpongeBob. I haven't seen it in a while. So let's talk about the presentation, how this hyponatremia will be presenting. You'll typically see that a lot of cases that are more mild generally present asymptomatic. So especially if it took a longer period of time for it to develop, so like say more than 48 hours, it will take some time for it to actually sort of kick in basically before they really become symptomatic. And again, these are patients that are like in the 125 to 134 range. So not terrible, but it's not ideal. You're going to find typically neurologic symptoms are going to be presenting here. So maybe like some malaise, maybe some headache, lethargy associated with this stuff. But you will find that the more rapid the case is here, the more in the magnitude, will present with more symptoms. So if it was something that happened very quickly, and the magnitude is quite large. So as I mentioned, like someone who had taken Molly, it was coming in and all of a sudden they went from a normal sodium, and then 8 hours later their sodium's like 110. They're going to be severely sick. They're going to be seizing. They're going to have potential for things like brainstem herniation. It's not great. Because again, one of the things you got to think about too is like, why did their brainstem herniate, right? Well, they have hyponatremia, and so they're basically the sodium content of the brain is higher than that of the blood, so it's going to draw water into the brain and can lead to increased pressure. And there's only one place for all that brain to go, and that's out the bottom essentially. And so again, that's why we see death happen with a lot of these cases. Very sad when it occurs. Obviously, for laboratory testing, if you have a sodium less than 135, pretty obvious diagnosis there of hyponatremia. And then you can look at things like plasma osmolality, urine osmolality. That can give you some clues too in terms of like, well, is the kidney concentrating? Is it not concentrating? You want to look at other stuff like kidney function, thyroid function tests, and things like that. As I mentioned with the cerebral edema, typically, again, that's related to the speed and change. The brain can adapt over time, Usually takes some days for that to occur there. So like, 48 hours maximally, but the faster the shift, the worse it's going to be in those cases there. As I mentioned, having low serum osmolality causes inward shift of fluids to the CNS. And again, it's a fixed space, right? So there's only so much volume that can, additional volume that can handle there. So it's also really interesting. Why I love talking about this stuff is because the correction is also can be worse than the disease itself in some cases, because you have to be really careful not to correct hyponatremia too quickly, because this can lead to basically having this water rushing out of the brain cells and the intracellular fluid, and it will contract, and that can lead to decreased brain volume and can cause something called osmotic demyelination syndrome or central pontine myelinolysis. Okay, so if I go from having low serum osmolality, especially if I had time for the brain to correct over, say, over the course of a day or two, and then all of a sudden I'm pushing 3% normal or 3% saline into that patient there, that's going to cause all that water to rush out. The brain's going to shrink basically, and is going to cause a demyelination syndrome, which can kill the patient, right? Or lead to things like Parkinsonism or quadriparesis, and some of this may not be really reversible, especially the death part. That tends to be permanent in a lot of cases. And this may take time to manifest within a week or so. So again, the more adaptation that the brain has had, the more cautious you have to be in correcting. The slower you have to go in correcting it, because too fast, you're going to cause some problems there. Let's see. Someone said, could you ever be so hyponatremic that drinking seawater would actually be beneficial, or is the ratio still too hyponatremic? I don't know. I don't know what the normal serum, what the normal concentration of sodium is in. Yeah, if you can figure that one out, Abby, then you'll be a gazillionaire, I think. Sodium concentration, seawater. 35 parts per thousand, which doesn't help me. Do milliequivalents per liter. I know this is like probably not super fascinating to you guys, but I'm really curious now. I'm not finding something right off the top of the... Anyway, I'm sure it is too much. So in that case there, I would probably say that the tonicity of the seawater itself is probably still pretty aggravating to the stomach, so you probably wouldn't be able to keep it down for very long. It does cause quite a bit of vomiting associated with that, so I would not recommend it in that case there. Yeah, I'd have to do some more research into that, but that's an interesting question. So thank you for asking that. I'll be thinking about that for a while. Brian's asking, what's the prevalence of locked-in syndrome? I hope not very high. It might be difficult to determine in some cases there, but that's where basically the patient's like awake and present, even though their body is basically paralyzed. That's why it's really, really important, and we'll talk about this in the surgery section later on. Anytime you have a paralyzed patient, you better make sure you have good sedation on board, because you do not want that person to be awake and conscious when they are receiving a paralytic. Whether it be due to disease or the drug itself. So we'll talk about that a lot more later on there. But so treatment, generally, if you can fix whatever the underlying cause is, like that's good. So if the patient's on carbamazepine and they're hyponatremic, we'll get them off the carbamazepine, switch them over to something else potentially. And then again, we're balancing the risk of the continued hyponatremia versus the osmotic demyelination syndrome. Okay. So what we're going to find is that for the most part, if you can correct it with just normal saline, that's the safest way to do it. Okay. So for instance here, if you have a hypovolemic hyponatremic patient, well, they need volume, so just give them normal saline. And that normal saline has roughly a normal sodium amount in it, 154. It's a little high, but it's okay. It'll correct our patient relatively easily. For patients who are euvolemic or hypovolemic, we may need to manage this with either water restriction. We'll talk about a few options here, like demeclocycline in just a little bit, or we may need things like NS plus a loop diuretic. So we'll look at some options there in just a few moments. And then for really severe hyponatremia, so like someone who's having like acute neurologic symptoms, if they're having seizures especially, then we're going to use hypertonic saline in order to correct that. So we'll talk more about these details in here in just a moment. So for acute or severely symptomatic hypotonic hyponatremia patients here, we're going to manage this with something like 3% sodium chloride. Some places I've even seen 23.4%. So again, as long as you're using the correct volumes, you can rest assured you're given the right amount. But again, anytime you're dealing with something more concentrated than 0.9%, act like you're dealing with a loaded gun, because it's very easy to overcorrect and cause issues for your patient there. And again, look at the concentration here, 513 milliequivalents per liter for 3% versus 154 for normal saline. So very concentrated versus what our normal serum sodium is. So again, you're going to find most patients will require about a 5% increase in their serum sodium, but you can kind of target about 120 milliequivalents per liter. Again, that's not normal, but it's at least a reasonable amount, reasonable level that we shouldn't expect them to be all that too symptomatic there. One other thing we can do as well is to look at the urinary sodium versus the corrective fluid, because in some cases with like SIDH, actually by giving them normal saline, it can actually worsen the hyponatremia. We'll talk more about that in detail in just a few moments here. And then if you're worried about volume overloading the patient, giving too much volume, you can use loop diuretics as well. You lose a little bit of sodium there, but it won't be nearly as much as what you're giving them through the IV fluids typically. So looking at this here, if patients are hypovolemic, as I mentioned, just use normal saline. That way it'll correct both the hyponatremia and the hypovolemia. Even though, I said a lot of that stays in the intravascular space, eventually it will partition out to the tissues. It just won't be super fast there. If they're hypervolemic and they're hyponatremic, they can be pretty difficult to treat because you don't want to worsen things like, pulmonary edema and things like that. So in those cases there, you may have to use a combo of like a concentrated sodium chloride plus a loop diuretic in order to help get rid of the extra volume they don't need while still getting in a large amount of sodium in those cases there. That doesn't happen too often, but it can occur. So for, as I mentioned, the acute or severely symptomatic patient here, how do you determine how much I'm going to change that patient's serum sodium by giving them an infusion of a given amount of sodium chloride? So this is actually a good calculation you can do yourself in order to figure out, okay, if I give a liter of fluid to this patient, how much is it going to change their serum sodium? Because again, you want to make sure you don't go any faster, and this is a good takeaway point here. Don't correct faster than 12 milliequivalents per liter in the first 24 hours. If you correct over that, you're increasing your risk for the demyelination syndrome, which is no good because that's a big medical oopsie on your record, and you might get sued, right? You don't want to do that. And you want to keep your patient alive. So anyway, as I mentioned, our goal is to get between 125 and 130. If you can only get up to like 120, that's probably fine as well. Just don't do more than 12 in the first 24 hours. You have time. You can correct it after that, as long as the patient's not like actively seizing. So when looking at this, how do we figure this out? Well, basically we're going to figure our change in sodium, the delta of sodium, is based off the sodium in the IV fluid minus the sodium of the patient's serum. And then we're going to get the difference between those two, and then we're going to divide that by the patient's total body water plus the volume of the IV I'm administering. So if it's 1 liter, I can just put 1 liter there, put 1 in the case there, right? How do we figure out the total body water? For most patients, and again, this may not apply to everyone, but in general, you can say, okay, well, 0.6 liters per kilo for men and 0.5 liters per kilo for women. So if I went ahead and had a female patient weighed 100 kilograms, I'd say, okay, they have 50 liters total body water. If I had a male patient that was 100 kilograms, I'd say, okay, 60 liters total body water. I can use that for the calculations. Keep everything in liters for this, in this case here, okay? So then you'd say, okay, well, if I have 60 liters in this patient, I'm adding an extra liter of fluid. That's where I get my denominator from. And then I figure out what the change in sodium is going to be based off the difference between the sodium in the IV versus the sodium in their serum. Okay, and that will overall give me my change in delta NA. So let's give an example. Let's say we have a 66-year-old woman who's presenting to the ED for vertigo and disorientation. She started carbamazepine 10 days ago. Serum sodium is found to be 108 milliequivalents per liter. You go, wow, that looks pretty low. Maybe we should do something about that. So step 1, discontinue carbamazepine. Pretty straightforward there, right? Now we want to get our desired serum sodium back up to 120 because again, we don't want to go more than 12 in the first 24 hours. Okay, so she's 108 now. Add 12 to that, we can get her up to 120 in 24 hours. Okay, so first off, let's figure out how much of a change in serum sodium I would get by giving this patient a liter of 3% sodium chloride. I'm not going to give that much because it's probably going to be too much, but how much would it change if I gave them a liter here? And that's going to help to guide me. So I basically say, okay, well, if I know my 3% sodium chloride is 513 milliequivalents per liter, and I know my patient's serum is 108 milliequivalents per liter, right? So that's my numerator here, the difference between these two, which is 405. And then I take my total body water calculation of 0.5 liters per kilo, because she's a woman, times 60, plus that 1 liter of hypothetical fluid I'd be administering, I'd get a denominator of 31. So 405 divided by 31. I would see if I gave that patient a liter of 3% sodium chloride, I should see a change in her serum sodium of 13.06 milliequivalents per liter. Now we said that's too much, right? But it's good to know because then I can figure out, okay, well, how many mLs do I need to give in order to get 12, right? How much volume do I need to get in order to get a change of 12 that I'm actually looking for, okay? In this case here, my desired change would be 12. So I could just say 12 milliequivalents divided by 13.06 milliequivalents per liter, and I would have to give 0.919 liters, or just 919 mLs of 3% sodium chloride. Okay, so I could give that over a 24-hour period, and I should get a serum sodium 120 by the end of that. Maybe a little off, maybe a little higher, maybe a little lower, but that is the general rule of thumb. Okay, that doesn't make sense so far. Let me know, and I can kind of go back through it. For the testing purposes, I'm not going to make you like calculate all this stuff out, but I'm trying to illustrate to you how you would go about doing this process here, because it may be something you have to do in the ER, right, or in the ICU potentially. Now, how would this change if I wanted to use normal saline instead? I wanted to illustrate to you kind of the difference between these two here. So if I had the same clinical situation, the only thing I'm changing now is the IV fluid sodium concentration, which is now 154 milliequivalents per liter. Okay. If I look at that, I then go through the same calculation. Basically, I'm going to find out that a liter of normal saline would only change her serum sodium by 1.48 milliequivalents per liter. So in order to get that 12 desired change, I'd have to give her 8.1 liters throughout the day, which if you did that, so 8,100 mLs divided by 24 hours, she'd be getting a fluid rate of 337 mLs per hour. That's way too much, right? Normal replacement rate is like 125 mLs an hour for an adult. So obviously it would seem sort of impractical to do just normal saline. It would take too long, especially if the patient's symptomatic. So sometimes what you'll do is you may do like half and half. Maybe you'll go ahead and do half for the 3% sodium chloride, and then once that's sort of corrected a little bit, then you switch over to the normal saline, right? So you can still get the same change just by modifying how much of each fluid you're going to be using there. Okay, so Priya is asking, where'd you get the 60 and 0.5 liters per kilogram times 60? So her weight is, which, did I include the weight? Oh my goodness, I think I didn't include that. I'm sorry. Let's assume her weight is 60 kilograms. Boy, that would be an important piece of information. It'd be nice if I actually provided to you guys. So we're just going to say weight is the 60 kilograms, which is not, too unusual. Oh man, that's really ugly. Anyway, so hopefully you guys get my point there. So weight is 60 kilograms there. So hopefully that makes sense. I apologize for that. That was my goof. So anyway, in case of non-emergent causes for hyponatremia, you're going to see here you can use sodium chloride over the 3%. The main benefit here is you really risk overcorrecting your patient there. Yeah, thank you for pointing that out, Priya. I appreciate that. So if anytime you can use normal saline over 3%, you're always going to be using a less risky substance, because we're going to see issues of hyponatremia can be a problem too. And in fact, we treat 3% saline kind of like a loaded weapon, like we make sure we handle it with care, because if we were to accidentally send out a liter bag of 3% saline instead of a bag of normal saline, and that were to get hung on the wrong patient, that can kill them, right? That's a big problem on our end. So we always really want to make sure we're treating this with a healthy respect. Let's see. Someone said, is there a preferred length of time to infuse the fluid so it's not too fast? Not necessarily. If it depends on the volume status of the patient, in terms of how much you might want to give. If it's something where you're trying to like replace a lot of fluid because they're hypovolemic, you may go like 1.5, 2 times maintenance rates, right? You may do a couple of boluses. So it really just depends. And again, you can do a liter of fluid. I mean, there's level 1 machines that can infuse it in a trauma situation like in 30 seconds or something. Like, it's very fast. If you were to just do it via like a pressure bag or something, maybe 15, 30 minutes or something like that, you'd be able to get that in. But yeah, so you can administer it fairly quickly as long as you're doing like a single bolus. But for maintenance rates, you probably see like 1.5, 2 times maintenance if you really need to replete their volume there. Against one of those it depends situations, for sure. Okay. So again, and also if they're hypovolemic, the 0.9% really helps to replace that volume, which is good. Okay. Let's say we have someone with SIDH. Typically, they're hyponatremic, probably not like an immediate like, oh my goodness, they're going to start seizing kind of situation there. But again, here the first thing we want to do is try to remove any offending drugs if we can identify them. So if it was something like carbamazepine or something like that, get rid of it. And then we can restrict water as well. And again, the thirst response is going to be quite high, so we want to try to make sure they're not going to be sneaking ice chips and water and stuff like that. And try to get them down to like a water intake of like 1 to maybe 1.2 liters per day there. In some cases, what we're going to do is we can actually give them sodium chloride tablets try to bump their sodium back up, and actually give them a loop diuretic along with that. Now you may be thinking, wait a second, why would I give a loop diuretic in this case here? It's not going to lose some sodium, and yeah, you're correct, it will. But also keep in mind that when the kidneys detect that in the macula densa, they're going to say, hey, we're losing too much sodium here. Let's go and try to hold on to this stuff. So it's going to try to help it augment the sodium water excretions. That way, you're going to get rid of some of that water there, or at least the increase in sodium is going to cause you to be in a state where you can, okay, get rid of that water, hopefully shut down some of the ADH production there, and kind of come back into balance, right? Because again, they're hyponatremic typically because their water volume is too much. You want to get rid of some of that extra water. And so yeah, loops will get rid of a little bit of salt, but more often they're going to get rid of a ton of water. And again, you're supplementing with a sodium chloride tablet. So that's how we're basically going to be running that show there to try to end up correcting those patients. So a couple of different things we can do to try to fix this as well from a drug standpoint. Say if this water restrictions and the sodium tablets are not working, we can give them some things that try to sort of blunt the response of antidiuretic hormones. We have a couple of things we can do here. One is demeclocycline. This is a tetracycline derivative, so kind of similar to tetracycline, doxycycline, and basically will inhibit tubular AVP activity. So even though the AVP may be getting released by the brain, it's not able to interact with the kidneys as easily, and thus you actually induce a diabetes insipidus. Kind of interesting, because now we're trying to cause the opposite problem in order to correct this. May take a few days for it to kick in there. And keep in mind, don't get this to patients who have like compromised fluid intake, because you can actually increase the risk for AKI if they have liver disease, and definitely probably wouldn't want to use this for long term, like more than a week in pregnant patients and young patients less than 8, because you do worry about it binding to calcium in the bone and the teeth and things like that. That would be certainly a consideration there for those type of patients, right? Just like we would see for any other tetracycline. We also have a few vasopressin receptor antagonists. There's a few different vasopressor receptor types. Vasopressin receptor 2 is the primary one we're going to be looking at here. This class of drugs is typically called the vaptans, because all the drugs in this category end with vaptan. So we have 2 here. We have conivaptan, which is more so for like in-hospital use since it's IV only. And then we have tolvaptan or Samsca, which may be used on a more outpatient basis, so they had more kind of chronic SIADH. Here you're going to see this is metabolized by CYP3A4, so you might want to look out if they have other interfering medications there. And you have to be really careful for this one since it's going to be contraindicated if they have anuria. So if they have existing kidney disease leading to anuria, avoid that. And then any hepatic issues can be exacerbated by this drug too, so I would want to watch out for that. Again, these type of drugs are not good for emergent correction of serum sodium. If you needed to do that in someone who had SIADH, you probably need something like a hyperosmolar sodium, like a 3% or something like that. So again, they have a hypervolemic hypotonic hyponatremia. This is where you need to have a negative water balance, and this is going to help to do that while also minimizing changes to the intracellular volume, right? So basically, again, if you can correct the underlying cause and you can limit fluid intake, that'll be helpful. And then again, if the issue is that they're holding on to all this fluid due to things like depressed cardiac function, then we can do things to try to help out with that. So for instance, like digoxin can increase contractility. Dobutamine might be useful for someone who's having a CHF exacerbation. ACE inhibitors and ARBs might be useful for helping afterload reduction to allow for better processing of those fluids. So those are the big things you can do for like your CHF patients or like liver disease with ascites or something that may be useful there. Now on the flip side, we have hypernatremia, where now we have too much sodium. And so this is either due to renal or extrarenal fluid loss. And so this may be due to hypertonic fluids being administered or ingested, excess sodium ingestion. Imagine just like, I don't know, going in, getting too many salty french fries, probably not likely to cause you to be hypernatremic, but you never know if you got enough of them perhaps. And then what we're going to see here is that, again, you can break it down into both hypovolemic and hypervolemic causes here. Typically, hypovolemic, this is going to be more seen so with like things like post-op diuresis, diuretic use. You can see this for sure, where basically you lose more fluid than sodium and it concentrates. One thing. We'll talk about diabetes insipidus and primary polydipsia, and then some of the for hypervolemic, this is usually due to things like concentrated tube feeding, so if they weren't diluted appropriately. If you had a medication containing a lot of sodium, this would be a cause for that. So too much fluid and too much salt in those cases there. So as you're going to see that a lot of times water loss occurs through insensible losses, right? Things we can't directly measure here. And so a lot of times patients, and because we can't measure insensible losses, so that's what makes them insensible, you're going to find that we oftentimes don't give enough free water to account for this in those patients there. Other big thing you're going to see is also going to be a diabetes insipidus. So this can either be due to your brain releasing less AVP, your kidneys not responding as well to AVP because they can develop a resistance there. And then if you have like a large, when that happens, though, you're going to get a large volume of dilute urine. Right? That's the main thing you're going to see there with diabetes insipidus is just a ton of fluid, but very dilute as a result of not being able to reabsorb a lot of that water through the AV aquaporin channel. So here we can see a lot of causes for diabetes insipidus. This can include head trauma. So it's funny that it can either cause head trauma can cause SIDH or diabetes insipidus. You can see both. Things like ethanol ingestion, as I mentioned, is sort of a central cause because it shuts down release of ADH. It's more of an acute sort of thing there. And then from a nephrogenic standpoint, you can see here off the demeclocycline, the vaptans we talked about. That makes sense because we just mentioned them. But things like lithium. And lithium is a very common thing I'll see in patients with bipolar disorder. Getting that, they can develop that again, they just come in there dehydrated, the sodium's up because of the lithium causing their kidneys not to respond as well to AVP. Right? A lot of reasons for that. So basically what you're going to see here is that with these patients are going to have a shift of fluid from the ICF to the ECF, so you can get sort of a dehydrating effect on the tissues. Should expect to see polyuria. And then as that you have that decreased neuronal cell volume, you can start to see some of those neurologic changes. Things like seizures can happen. Notice here that your body can usually handle hypernatremia better than hyponatremia. So here you may not find patients become as symptomatic until they get pretty high, like 160 or more. And again, the more acute the change is, the more quickly they're going to become symptomatic. So typically our goals here are to try to correct the sodium down to 145. And what we're going to see is if we correct it too quickly, similar to how if we tried to correct hyponatremia too quickly, we cause the brain to lose water. Here we can actually cause the brain to gain water, and it can cause cerebral edema, herniation potentially, so not great from that standpoint. So what we're going to see here is that we're going to continue sodium restriction, and then we will get fluid replacement to try to prevent recurrence there if at all possible. So from that standpoint, consider using something like normal saline. Now you may be thinking like, well, wait a second, like normal saline, that's 154 milliequivalents per liter. This patient's already sitting at like something like 160. That'll still bring it down, right? It's still less than what the serum is, and that will help to dilute it out to a degree. And again, it's going to slow down that change, right? You're not looking for a super quick change unless they're acutely symptomatic. And then at that point, once they kind of get back down closer to normal levels, you can switch them over to something like half NS to bring it down even lower. Just be aware that using that half NS is going to really drop them much faster, especially when they're at really high levels than a simple NS would. And again, you could do the same calculation like we did before. You would just have to flip it to use the serum sodium being higher than what the IV fluid is. But you can see what the change would be based off of giving like a liter. Similar rule here, you don't want to correct more than 10 to 12 milliequivalents per liter per day. And again, if it occurred quickly, after several hours, then you can correct basically 1 milliequivalent per liter per hour. If it was something that happened like in the course of like a day or something, right? If it was a course of like several days or a week, you gotta be slow with it. Don't go more than 10 to 12. If it was an acute thing, like with the course of hours, then yeah, you can probably do a little bit faster than that. Usually, 1 milliequivalent per liter per hour. For patients who have central diabetes insipidus, basically we can try to replace missing AVP by giving them desmopressin, which is otherwise known as DDAVP. This is actually a drug we have to administer nasally because it has pretty poor bioavailability here. And this is going to help us to be able to concentrate the urine a little bit better because we're able to basically replace the AVP that they're missing there. Again, you're going to see things like urine volume, or we're going to use this to get to a correct urine concentration, especially to prevent things like nocturia and things like that for these patients. So some patients will have kind of like chronic diabetes insipidus that just may be on this drug chronically, right? It doesn't always have to be an acute thing. And typically you're monitoring the serum sodium, monitoring the urine volume to keep that sort of in line there. Just be aware of here that you can kind of overshoot it because you can cause risk for water intoxication and causing you to consume too much to do that thirst response. You do have to monitor for that for sure. I don't know if anyone's ever heard of this before. There's a case of there's like a radio contest. It was back when the Nintendo Wii first came out, and it was like, you know, super popular. Like everyone wanted one. It was impossible to find, and they had a radio contest where it was called "Hold Your Wee" for a Wii, and they basically had these people drink like a huge amount of water, and they whoever could hold their urine the longest would basically win a Nintendo Wii, which is like, you know, everyone wanted one. So you could do the Wii Sports and whatnot. And so one lady actually ended up dying from hyponatremia. So it's like this polydipsia induced hyponatremia, and ended up actually dying and seizing from that, seizing then dying from that. And of course, the radio contest was probably not redone, if I had to guess. That sounds like it would be a legal nightmare. But anyway, so yeah, don't hold your urine for too long. If you need to go to the bathroom, just go. Regardless, though, yeah, it was not great for sure. So again, looking at this nephrogenic diabetes insipidus, again, if you can figure out a causative agent, get rid of it, that's great. Like if it was lithium, for instance, you could try to remove that and switch them to something like valproic acid, for instance, and try to correct any electrolyte disturbances they have there. So this is another case here where by actually causing a mild extracellular fluid deficit by using something like a thiazide with salt restriction, you can actually end up cutting the urine volume. This is actually pretty neat because basically by doing that, the proximal convoluted tubule is going to be reabsorbing that water and ultimately decreasing that filtrate there. Because remember that you're going to find that the thiazides work at the distal convoluted tubule. So if the kidneys are detecting that, it's going to say, well, I need to reabsorb water elsewhere. And so it's going to do it at the proximal convoluted tubule. And thus you get less urine volume overall. So it sounds counterintuitive to get someone a thiazide diuretic for diabetes insipidus, but it actually ends up working out pretty well for them. Another thing that can help AVP work even better is something like indomethacin, which is an NSAID that can be used occasionally as well. For sodium overload, obviously, if you can limit sodium intake, that would be helpful there. Loop diuretics can help to kind of assist with getting rid of some of the extra sodium there. Very rarely do I ever see D5W. I think that would probably be very rare indeed. Maybe something like a half an SD5, because using just free water would correct them way too quickly, I think, in those cases there. But yeah, limiting the sodium intake is the best thing for that. So any questions on that section? Fantastic. I have enough time. I thought I was going to be like talking about that the whole section. My green screen software is goofing up, so it looks like I have like something behind my head, maybe on the other side. But I assure you that's just software goofing out. No questions on the board, so I will continue at pace. So let's talk about urology. Erectile dysfunction being the first thing we're going to talk about here. So basically, this is going to be defined as someone who's having issues in terms of either achieving an erection or something suitable enough for intercourse for 3 months or so. You may hear the term impotence being used here. But again, it's not usually such a cut and dry case. You'll actually find that it can come about from various different aspects. So for instance, it could be an issue of decreased libido. It could be an ejaculatory disorder, or it could be related to infertility as well. So, again, I think most people are familiar with the drug Viagra, right? It's like, oh, Viagra fixes all impotence, but may not be the case, right? You may have underlying other issues that could be happening here, which we will discuss and talk about. Typically, fairly low in presence or prevalence in patients less than 40, but it does increase with age. Some people think, okay, it's just part of aging. It's just something that's going to happen. But, certainly have good medication management for this. And you're going to see this is oftentimes can be exacerbated by other conditions. So like hypertension, psychiatric disorders, medications, which we'll talk about specifically, diabetes, all this stuff can tend to make it worse, right? So basically, if you're looking at the physiology of the penis here, you can see it in this cross section, which basically there's two corpus cavernosum, and during the flaccid state there tends to be a balance here between venous and arterial flow. What happens during an erection, for whatever stimulus that's happening here, we're going to see that we're going to have increased arterial flow in, but we're going to have decreased venous flow out. That was what leads to tumescence, right? Is what leads to the erection developing there. So again, that flow is going to be really important there. We can find that by altering that blood flow, some of our medications, we can have pretty strong effects on how to affect this. So what can affect the arterial flow? We'll see this gets mediated through things like acetylcholine, helping to enhance the activity of cyclic GMP, along with cyclic AMP, is going to allow for more blood flow coming in. Another really important bit here is the substance called nitric oxide. Nitric oxide also stimulates the production of cGMP, and that allows for less calcium to flow into that vascular smooth muscle, and it relaxes it and allows it to flow in, right? Just like we talked about with your nitrates. Remember, we talked about nitroglycerin causing vascular smooth muscle relaxation. It was through the increased production of cGMP, right? So again, that's an important point to remember because that's going to be come up later on. We'll also see acetylcholine is helpful to enhance cyclic AMP production, which again we'll get into more details on here in just a little bit. Now, of course, we need to have some sort of psychogenic stimuli that occurs here. This is why you can see patients with spinal cord injuries can develop impotence because they don't get the right signals being sent from the brain down in order to say, hey, it's time to develop an erection here. Also notable is you can also have some hypothalamic responses here that help to integrate external stimuli. So this is actually a problem where patients may not be able to take an external stimuli that would stimulate an erection and actually be able to process that into sending the right signal down to the penis, right? So this could be a case where, for instance, dopamine normally exerts pro-erectogenic effect, right? Which if you didn't know that's a word, that's a word. But dopamine normally exerts that. So if I say have a patient who has schizophrenia and they're on a dopamine blocker, well, then maybe that could be a cause for their impotence, because even though they may have a normally functioning set of genitalia, they don't get the right signal being sent down work, right? Other things like alpha-2 stimulator, alpha-2 agonists like clonidine can cause, can inhibit erections too, right? So that could be another case where you can see that the signals can be affected more centrally than it is more in the periphery. That's why you need to identify some of those causes, because if you can identify one of those, you can fix that much easier than adding on just another drug, right? Normally, detumescence is going to be mediated by norepinephrine, which will be important for how you can actually treat inappropriate erections, as we'll see in a little bit. And that actually causes the vascular smooth muscle to clamp down, decreases arterial flow, and then the venous outflow will then increase. Okay, so we'll restore that normal balance there. Let's look at some hormonal effects that can affect the ability to develop an erection. Testosterone typically will start to decrease after age 40 or so, and this is an important stimulant for libido. And you're going to see here as well when we talk about the prostate more specifically. So this is kind of more of a guy-oriented, a male-oriented sort of lecture, as we're going to see here. But normally the enzyme 5-alpha reductase converts testosterone over to DHT, which we mentioned is a more sort of androgenic sort of hormone here, and it also helps to enhance the growth of the prostate. So we're going to see that may be some issues there because patients may have BPH that's being stimulated by DHT, but also we need that DHT around to help stimulate libido. So that can be sort of a double-edged sword, as we're going to find here in a little bit. We do know that small amounts of testosterone does get converted over via the aromatase enzyme into estradiol. We all have a little bit of estrogens being produced there. And you want to be careful trying to interpret testosterone levels in patients with erectile dysfunction, because you may find there's a really kind of wide range in terms of what's considered normal. Free levels may be somewhat useful in order to determine if this is an issue or not. And again, try to figure out by talking to the patient, is this an issue of decreased libido or is it actual erectile dysfunction, right? They feel like they want to have sex, but they're not able to achieve an erection. That's different than just saying, like, I just don't want to have sex anymore, right? So keep that in mind. From a pathophysiologic standpoint, we can see certainly things like vascular disease can lead to this, things like arteriosclerosis. Certainly, we talked about neurologic issues like stroke, spinal cord injury, diabetes even can cause some neuropathies that may lead this to be more difficult. And then certainly things like hormonal changes like hyperprolactinemia can inhibit this, testicular removal, obviously. And then there's just kind of natural organic erectile dysfunction that affects probably the majority of people, and this usually due to these causes here. Now, certainly there can also be things like psychogenic erectile dysfunction. This would be in the case of imagine someone was having a heavy night of drinking, and then they were not able to have sex afterwards. That could be like an actual issue of having the actual external stimuli being able to process because they passed out or something like that. And again, a lot of times it could be multifactorial. It could be depression affecting the erectile dysfunction, could be anxiety, could be a myriad number of cases here that could be affecting on all sorts of levels here. But remember, patients need to be in that sort of proper mental frame of mind. So, they can have reactive depression as a result of the inability to perform, which can kind of exacerbate that. They may have issues with things like hypothyroidism, mental disorders. So a lot of things can go into this. So again, trying to deal with the behavioral health side of things may be really beneficial in conjunction with some of the medical therapy we're going to see here in just a little bit. So looking at drugs, you can see this may be a cause for erectile dysfunction about 10 to 25% of cases, so fairly common. We can see things like antihistamines and sedating drugs, anti-Parkinson drugs can all lead to this. And especially when looking at, some things we can try to do to get around this, things like using second generation antihistamines, right? Maybe able to reduce that. It's going to have less effect on the ability to produce that cyclic AMP. We're going to see things like, TCAs tend to be worse than SSRIs, which tend to be worse than SNRIs. Bupropion tends to be the best in terms of depression medications that are going to cause sexual dysfunction, right? It's not guaranteed it's not going to happen, but it's going to happen less than with things like your SSRIs and TCAs. Then, as I mentioned, the dopamine antagonists, things like your phenothiazines, all of your antipsychotic, first-gen antipsychotic drugs, metoclopramide, again, they're going to be blocking dopamine, which also increases prolactin levels, right? And that decreases testosterone production. So you can see how it's kind of multifactorial there. Looking at from a hormonal standpoint, again, we can see that a lot of drugs can help to suppress testosterone mediated libido stimulation. So if someone had like estrogens on board, anti-androgen drugs, which we're going to get into extensively in the BPH section, even drugs like digoxin can do this. We certainly talked about things like spironolactone. And then a big cause for this too, more of that sort of psychogenic ED, can be related to CNS depressants. So any kind of sedating sort of med may make it more difficult to achieve an erection and be able to perform coitus. So things like your benzos, opioids, large doses of ethanol, as I mentioned there. And again, a lot of this is related to suppressed perception of those psychogenic stimuli. So if they're not able to process the external stimuli that would normally cause an erection, then it doesn't happen, basically, or they pass out or something. So there are a lot of agents that can decrease penile blood flow. So this typically is where you run into a lot of problems with your hypertensive drugs. So things like beta blockers, diuretics, central sympatholytics. All these are reducing arterial flow to the corpora. So if you don't have that increased flow, then you can't achieve an erection there. So that's a common complaint with things like diuretics and beta blockers, and may lead to patients wanting to discontinue it and switch over to something like an ACE inhibitor or an ARB. Calcium channel blockers also have a relatively low incidence as well, so that could be a good option there. And then from other agents, we'll talk about finasteride and dutasteride a little bit later on, but things like MAOIs, lithium, gemfibrozil, kind of a hodgepodge of different things there. So what I want you to kind of know from this is like kind of think about the mechanism for the drug and like why it would lead to erectile dysfunction. Or if I gave you a list of medications a patient's on, and it said, yeah, he's just having decreased libido, doesn't really want to have sex anymore. What could be causing that, right? Which of these drugs is most likely? Or if it's not an issue of libido necessarily, but more of a problem of being able to generate an erection, maybe it's more of an antihypertensive kind of problem, right? So those are kind of things I want you to think about there. Maybe I could be like, patients on, haloperidol, a beta blocker or whatever, and he's complaining gynecomastia and decreased libido. We might say, okay, well, it's probably, the atypical or the first gen antipsychotic that's doing that, right? So little things like that you may want to think through. Obviously, you get a good list of their medications, concomitant disease states, thorough history, and testosterone levels can all be helpful here in terms of trying to figure out what is going on. Excuse me. So for these patients here, what you want to do is try to increase the number, quantity and quality of suitable erections for them. Make sure they have reasonable expectations for what they can expect to consider to be like successful therapy. And then obviously we only want patients with legitimate complaints. This is kind of an interesting thing to consider from a diversion standpoint. But we had cases where we had in certain pharmacies I've worked at, they kept things like Viagra locked up in the same vault that we keep things like fentanyl and Percocet in, because there was a concern staff members and things like that, stealing medication because of, I don't know, I guess wild curiosity, or maybe they felt like they could perform better in bed, who knows. But yeah, so make sure patients have legitimate complaints, actually have troubles developing an erection, because we'll see these meds are not without side effects. We'll see in a minute. Isabel saying, could that also be spironolactone for the gynecomastia and decreased libido? For sure, mainly because it is decreasing overall testosterone activity for those patients. It may have a little bit more estrogenic effects, less testosterone effects, and then there you go, you get both of those issues there for sure. Obviously, if you can correct any kind of underlying disease states, alcoholism, smoking, psychotherapy, very helpful. And then we can talk about some of the pharmacologic managements. I'm not going to talk a ton about the alternative therapies, things like the vacuum erection devices and surgery, because those are not really in my wheelhouse so much. But certainly they are pretty popular among certain patient populations. I know that we'll talk about them a little bit later, though. Give you an example. Typically, we like to use things that have a fast onset, things that are efficacious, convenient, cost effective. I mean, I wish everything in life was like this. And then limited drug interactions. We're going to see that not everything listed here is going to be able to basically provide all of these things here, right? In general, if we can try to go least invasive to more invasive, because we're going to look at some of the things that are a little more invasive, that might not be as tolerable by your patients. So here's kind of the algorithm we're going to be flowing through here. So we're going to see that, again, treating underlying diseases, discontinuing meds that could be contributing, all of that good stuff. And then looking at first our phosphodiesterase inhibitors. We've already talked about testosterone supplements back in the endo section, so we're not going to re-talk about those here. We'll talk about our phosphodiesterase inhibitors. We'll talk about, briefly some of the things like vacuum erection devices and surgery options there. But we'll see that the phosphodiesterase inhibitors are not working. Then we're going to try out our intracavernosal or intraurethral alprostadil. And those are kind of the big two groups of medications we're talking about specifically for erectile dysfunction. Someone said, let's see here. So as far as mechanism, can you explain why CCBs don't cause erectile dysfunction? Yeah, because if you think about it, like, vascular smooth muscle relaxation is what you need to achieve an erection. So if that's what calcium channel blockers do, right, then it would make sense that they can actually, if anything, maybe not help it necessarily, but they certainly aren't going to hurt it. And so in that case there, that's why they're thought to not really be as often linked to erectile dysfunction as you would see with something like a beta blocker or a diuretic or something like that. Hopefully that makes sense. So with the vacuum erection devices, this is typically using negative pressure to draw kind of more blood flow into the cavernosa. Obviously, it's going to be something that is pretty fast in onset, but it's not really all that discreet. It's got to get a whole device out and stuff like that. But so it may not be super tolerable for your patients from that standpoint. However, if they have contraindications like certain cardiac disease, things like that, and they could not take the phosphodiesterase inhibitors. When I say PDE5, that's what I'm referring to. So in those cases there, this might be good, or they can maybe be used in combo with other things until they can get surgery, potentially. We'll talk about the surgical options at the end here. So I'm not going to talk about this too much. But let's talk about our phosphodiesterase inhibitors. These are kind of like mainstay gold therapy or gold standard therapy for treatment for erectile dysfunction. And I want to try to get through this before the end of class here. Basically, what's going to happen is that normally you have sexual stimulation of the patient. You're going to find that nitric oxide gets released from these nerves here, and it's going to be affecting the endothelial cells. What that nitric oxide does, and remember that's not nitrous oxide, that's laughing gas, nitric oxide, it's going to be stimulating guanylyl cyclase. That's going to increase cyclic GMP production, which then causes smooth muscle relaxation because it blocks calcium from coming in and thus causes increased blood flow and you get an erection, right? Now, it's important to maintain that balance. I'm sure most of you have probably heard at some point in your life an erectile dysfunction commercial. They say, well, call your doctor if you have an erection that lasts more than 4 hours. Why is that? Well, because, if you don't have good blood flow going to that tissue, it can become gangrenous. It can become ischemic. That's not great. So how do you counterbalance that? How do you get rid of that cyclic GMP? Well, that's where you have the enzyme phosphodiesterase. Normally that will convert the cyclic GMP to a more water-soluble form where it can maybe be recycled. Here you just see guanosine monophosphate. And that's going to be how you get rid of the erection, basically, along with things like norepinephrine, decreasing blood flow. So what would happen if I inhibited that enzyme phosphodiesterase 5 by using something like sildenafil, vardenafil, tadalafil, or evanafil? These are our main phosphodiesterase inhibitors. Well, I'm going to have more cyclic GMP around. I'm going to have more relaxation of the smooth muscle, and have an easier time generating an erection. So there you go. That's how these drugs are going to be working here. You can see the various ones. How we select the ones we will choose will vary depending on things like how long we need them to work for and a couple other factors, which we'll see here in just a little bit. We'll have things like sildenafil, vardenafil, tadalafil, and evanafil. So you can always tell if it's a phosphodiesterase inhibitor because it will have fil on the end there. But basically, these work to inhibit the actions of PDE5, phosphodiesterase 5. This is important because that one is specifically related to its effects on the penis, and then also in the lungs as well. We'll see here that these drugs can also help out with smooth muscle relaxation in the lungs to treat things like pulmonary hypertension. So we actually use things like sildenafil and tadalafil in a pediatric hospital. And you're like, well, why in the heck would you ever do that? We even use it in little young female patients. And you're like, why would you give that to a female patient? Because they have pulmonary hypertension due to, like, congenital heart defects or something. So again, there are other uses for it, and it's because it is specific for PDE5. Okay. Now, there are other versions of phosphodiesterase that are out there, and that's what's going to lead to some of the side effects. I will talk about those more at length here as we get into them. This table is useful if you want to go back and sort of look at some of the differences here between the drugs. Some of the highlights that I will note here are going to be their effects on various PDEs. So notice PDE 6 and 11. These will be important for side effects here, which we'll see in a little bit. So for instance, PDE 6 is more affected by sildenafil than any of the other ones, versus tadalafil affects PDE 11, while the other ones don't really affect it. We'll talk about what the implications of that are in a little bit. Also notice things like, for patient education points, you may want to talk about things like using a fatty meal to increase absorption, or I'm sorry, decrease absorption. So you may want to eat it with more of a lean meal, as the case may be. I'm not going to test on that though. But one of the important things here is the mean plasma half-life. So to see the actual duration of action for some of these drugs, kind of notice here the one outlier is tadalafil, lasting about 18 hours or so in terms of half-life. So obviously that may make a difference in terms of duration when you look at here, between 4 and 5 hours, all the way to 24 to 36. We can talk about ways we may want to use that differently depending on the patient we're dealing with. So as I mentioned, especially with younger patients, this is first-line therapy. It's fairly discreet. You just pop that little blue pill, the Viagra, and you're good to go, right? Basically, we're going to find out that you're selecting your agent based on adverse effects, duration, onset, and cost of treatment. I think nowadays, and again, I'm not big on the retail world. I'm not sure what insurance coverage is like for these nowadays. But I remember back in the day when I was interning, I guess back in 2006 or 7, I guess this was. Like, my gosh, I'm getting old. I remember, like, we'd have these male patients that would come into the pharmacy, my brief time in retail, and they would just like pay by the pill. They'd have a prescription for, say 30 days worth or whatever. But they were so expensive and they weren't covered by insurance, so they were only, getting like, 1 or 2 at a time, because that's all they needed, right? Usually come in on a Friday night, dressed to the nines, get their 1 or 2 tablets, and they're good for the weekend, right? So again, it really depends on the patient and kind of what they need it for, what their intentions are. Nowadays, I think it's more likely to be covered by insurance, at least from my understanding. But back in the day, it was more of like a lifestyle thing for a lot of people. So they just said, okay, we're not going to cover it. So probably not the best choice there. Anyway, so what we're going to see here is that these tend to be pretty effective for most people. The people who are less likely to respond well to it typically have comorbid conditions. So we'll see that. Rico Suave, Abby, you might be dating yourself there a little bit too. Somebody back in the 80s, right? Anyway, so what we're going to find here is that in terms of like therapeutic failures, why people may have a bad time with this are going to be related to things like food interactions. So if like a fatty meal will decrease absorption, then maybe they need to schedule around that or try consuming different food in order to prevent that. Typically, we'll give them between 5 and 8 sort of doses there to see how they're going to respond to it. And then they can titrate up on the dose, then it's not being as effective as they need it to be. And then again, you think about typical date night, you consume some alcoholic beverages, that can blunt how well these drugs are going to work from the more of the psychogenic sort of standpoint. So again, in that case there, maybe avoid excessive alcohol intake. And for the most part here, we're going to use this, we're going to avoid this in patients who have no erectile dysfunction, or patients who have certain kind of type of blood conditions, things like sickle cell disease, leukemia, multiple myeloma, or if they're on other erectile dysfunction meds, they're at risk for priapism, and this is not good because again, this is where it can lead to having, ischemia of the tissue. It's a urologic emergency, which we don't want to let just kind of sit there. So we need to make sure we manage that as best we can. Someone had a question here. Questions. If a patient doesn't have ED and they take a phosphodiesterase inhibitor, will they experience any effects? That's a good question. I think it's a misconception with a lot of these drugs here. Remember that the phosphodiesterase inhibitors only facilitate the development of an erection. If you never have the stimuli from the CNS down to say, hey, develop an erection, it won't do anything, right? So again, that's why we can use it like in little kids, and it's not really like an issue because, again, a lot of them tend to be prepubescent. It's not like that would be a concern anyway for them. So again, they still need the stimuli in order to cause that to occur. It's not like you just take it and all of a sudden have an erection, right? So in that case there, they may not experience much of an effect unless they have some sort of stimuli, right? Someone said, honest question, but is there a benefit of a 24 to 36 hour duration when you start risking issues you'd see with priapism? So that kind of goes right into that, is that, again, if you're lacking a stimuli, then, and again, if you're not mixing, matching these different meds, which we'll talk about more in a little bit, you shouldn't have an erection because the signal is not being sent down to produce cyclic GMP. This stuff only works on existing cyclic GMP and preventing its breakdown. Now, the question is, like, why would you want to use something that works 24 to 36 hours? Well, maybe if you're strapped for cash and you only have the ability to buy one pill, well, that can carry you throughout most of the weekend there, right? Or whenever your time to have sex is. So in that case there, it could be a convenient thing. They can just say, I'm going to take one pill, and then I don't have to think about it again, versus the other ones you'd probably take before each act, basically, so you take it like maybe that evening or whatever time of day it happens to be. Because again, it's only going to work for that 4 to 6 hours or so, right? So if it happens outside of that, then you may need to redose, basically. So from a logistical standpoint, that may work better for the patient, depending on the case there. And again, if this is awkward to hear me talk about, it's even more awkward for me to talk to you about it. So don't worry about that. Good thing you guys are distant. I can't see your faces. Otherwise, this would just be even more awkward and probably falling over my words even worse. But anyway, other things to think about too is that, again, don't mix meds. Don't use it with patients with hematologic disorders, because that priapism risk is going to be elevated there. Okay. So what are the problems you can run into here in terms of the phosphodiesterase isoenzymes that are other than PDE5? Because PDE5, think about this in the genitalia, think about this in the lungs. Those help to relax that smooth muscle. What about PDE6? That's typically found in the rods in the cones of the eye, which you can actually find that if you inhibit that, it can lead to things like blurred vision. It can also lead to a really unique side effect called cyanopsia. Cyanopsia, we talked about xanthopsia before, which means a yellowing of the vision. This can cause a bluing of the vision. I guess it would be the thing here. So basically, you'll see sildenafil as the primary cause of this. You will find the vardenafil is less likely, probably equal to vanadafil, and tadalafil least likely. So this is really a problem with sildenafil. With PDE11, that's mainly localized to striated muscle. So because tadalafil has the most effect on this, you're going to find this is most likely to cause myalgias. Okay. So the patient may be like, man, it feels like, I've been working out or I've ran a marathon. It could be related to the myalgias associated with affecting PDE11 in the actual skeletal muscle, right? So as I mentioned, within terms of onset, you're going to find within about, 2 hours or so, you should have pretty good onset of action of the drug there. If it's sildenafil or vardenafil, might be a little slowed down if you're consuming it with food there, especially fatty foods. As I mentioned, tadalafil has a slower onset, so it may take a couple more hours to really kick in, but then it's good for 36 hours, which may carry the patient through the weekend depending on the situation. In terms of metabolism, these are metabolized through CYP3A4, so you do want to make sure there's no interacting medications there. And then sildenafil and tadalafil do need to be renally adjusted if they have concomitant renal disease, which may be quite possible for these older gentlemen. You'll see. Other things you're going to be running into is because they allow for relaxation of smooth muscle, it just doesn't affect the genitalia. It can affect other things as well, as I mentioned. So you can see things like headache because you have dilation of cerebral vessels. You can see facial flushing. You can see dyspepsia because you have a relaxation of the lower esophageal sphincter. Nasal congestion can come about this. That's a good question, Alyssa. So the myalgias would be transient. So those should resolve on their own as long as the patient doesn't continue taking the drug. Cyanopsia is one of those things that should go away with time, but we're going to talk about one issue that can happen here from a vision standpoint that's going to be more concerning, as we'll see here in just a little bit. But yeah, both of those should go away as soon as the drug's out of the system. But again, you'll see due to this vasodilation, nasal congestion, some dizziness may be associated with that because, again, it's causing smooth muscle for relaxation elsewhere. You can see a little bit of a drop in your systolic blood pressure. Most people, that should be not a problem because it's mostly asymptomatic. Most people can handle that small of a change. If they're on multiple antihypertensives or if they're on nitrates, this is going to be a problem. They can really cause them to bottom out, and then they can have an issue there in terms of being able to perfuse things like the heart, for instance, right? So nitrates is going to be a really big no-no with the phosphodiesterase inhibitors we're going to see here in just a little bit. So if you have a really high-risk cardiac patient, I would be very cautious to use a PDE inhibitor or just not use it at all because of some of the risks you can run into here. Other things to worry about are going to be this photophobia, blurred vision. This is more likely due to sildenafil's actions on PDE6. As I mentioned, that cyanopsia kind of presents as like a blue-green color discrimination that you're losing there. This is generally reversible. The problem you run into is this called non-arteritic anterior ischemia optic neuropathy, or NAION, I guess, if you want to a little shorter on how to say it. This is basically a unilateral blindness that may be irreversible. So again, if you're telling your patient, hey, if you take this, if you go blind, don't take it anymore and come into the ER. That's certainly something that would be an emergent case for getting evaluated, right? This is thought to be due to drop in blood flow to the optic nerve, which you can imagine would lead to that blindness that can occur there. And it can happen after years of use, maybe happening after the first dose. It's really hard to determine when that might happen. Again, no clear case of who might be more at risk. It just seems to be something we see very rarely. As I mentioned, back pains, limb muscle pain, you're going to see a lot with tadalafil, mainly due to the PDE11 effect. And then vardenafil can cause QTC prolongation. So that'd be something you want to be careful if they're on other meds, if they're on, amiodarone or AFib or something, right? You can see that could then compound on one another there. And as I mentioned, priapism is typically rare. It's not super common to see that happen, but it's more likely to occur with higher doses and if they're on multiple erectogenic medications. Okay, so if they're on something else, we'll talk about some of the other classes here in just a little. I think I'm at my time here, so I think I'm going to cut off here because I do want to speak to this pretty extensively, and I want to bog down your time once you get to your break before you go to your next class. So we will get back to this tomorrow, I think, when we talk at 2:30. So I like to leave you on a cliffhanger, so to be continued. I wish I could do that thing from JoJo's Bizarre Adventure where they do like the to be continued, and I play it roundabout by oh shoot, who's that? Now it's escaping my mind. I've lost it all now. Anyway, yeah, thanks a lot. If you have any questions, feel free to post them up in the meantime, and I'll get back to you tomorrow. And you guys can have a great day. I'll see you all later. There you go. The greatest bass line in rock music ever written, I think. Liffy's in the biz. Very good. Thanks for your help. Appreciate it. You guys have a good one.